COMDIS, that was communicable diseases, and we still are communicable diseases, TB, for example, and particularly these days, multi-drug resistant tuberculosis, building on our previous work and continuing work on regular TB, and other communicable diseases such as the ones tackled through community intervention, community case management, pneumonia, etc. And today I'm focusing obviously on one particular area, which is our health systems and services strengthening work. So I'd like to make a pitch for calling it health systems and services strengthening. I'd also like to reorganize the WHO building blocks. So who are WHO anyway? So I'm proposing to reorganize the blocks a little bit like this. The bottom one, leadership and governance, underpins everything. You've got the health systems blocks, which are essential drugs, human resources, information and evidence, MIS, and health financing. And all of those are the utterly critical foundation for then having effective service delivery and strategies within that. And if we're successful with our service delivery and strategies, we then deliver interventions with good population coverage and quality, emphasizing the quality part. So in that systems or health service delivery, I should say, block, there's the usual thing that we think about with health systems, that is the numbers of health workers, the geographical coverage of the staff and the facilities, and that of course is critical. But as well, we need to think about, if you like, some of the software things that go in there that enable you to get to coverage and with quality, including thinking about the model of care or care pathways, and based on those, operational guides and tools which will ensure that you get the coverage and quality for whether it's bed nets, vaccines, or indeed with chronic disease care, for example, screening, testing, treating, following them up, continuity of care. So just going back to the blocks, the health systems ones that underpin that, obviously we need to ensure, for example, we work with non-communicable diseases and chronic disease care in general, including MDR, TB care. So we have to make sure that those drugs are included within the essential drug list. And which drugs? We need to ensure something relating to the information system, that the recording reporting is happening. Very focused things. Human resources, the right kind of training, etc., performance management. Health financing. I'll just give an example. We work in Africa and Asia. One of our partners is China. And in China, they have a rural and urban health insurance system. Now, I'll just make another little pitch, if I may, that, everybody focuses on catastrophic expenditure. So for non-communicable diseases, cardiovascular diseases, that's strokes and heart attacks. So, however, we find when we study this that the insurance system is not oriented to reimburse the preventive treatments which will prevent those catastrophic events and expenditures. So unless we research and study those things, we'll miss the point. So on some of our studies on TB, MDR TB now, and on the chronic diseases, cardiovascular, we're influencing the ministry in the reimbursement rates. Now this in China is very much a provincial and county issue as well. So I'll just give you an example of how to think of health systems when you're trying to deliver a particular tranche of the health service, such as MDR TB or non-communicable diseases or maternal services. Whatever tranche you're looking at, you need to be looking at those health systems things. So my premise is you can look at health systems, and you should, as a human resource and essential drugs, that's essential. But as well, you need to look at health systems from the point of view of the detail that you need to work with to make those tranches of the health service, such as TB, work. So my next slide is a bit of detail on that, and it gives a bit of learning from our consortium. And I'm going to give the example particularly of the two chronic diseases we're working with, non-communicable diseases and MDR-TB. So down this, the left-hand column, as you see it, are the health systems functions and human resources and HMIS drugs finance. And the other side, you'd have the various components of the health service delivery that we are working with. So we're particularly, in this case, for chronic disease care, working with the model of TB and applying it to MDR-TB and to non-communicable diseases. So we have a particular model of care which we think is appropriate for the common conditions and trying to prevent progress to these catastrophic events. So that's a focus on primary care, the health centre, and trying to develop an up-down referral approach. So people are actually being referred up for an opinion and then continuing to be cared for at the health centre. This doesn't normally exist in the countries we work in Africa and Asia. So this is developing something new. And it's not just acute episodes of care. You're trying to get those health services to recognize that these acute conditions are actually acute on chronic something. And then having screened, picked up those, whatever it is, such as a glucose, with the glucometer, the BP, etc., you then will put them into a continuum of care, continuity of care. So when we're working with the health system and trying to understand it, we have to think, well, what's the best way of delivering, for example, training for these conditions? We can't repeat everything that's been done before, where you bring people per diems to a hotel and provide a course, always these in-service trainings. We've got to get it into the basic training. We've got to get it into the continuing professional development, for example, so that it's paid for without having to be a program. And people have got demand because they need their CPD. And we put in place the operational guides, clinical guides, etc., incorporating that learning and models of care, etc., into those guides. So they're very tailored to the context. So one of the ways we work is we work with the government ministry program and our local NGO, that is the research development partner, to do this sort of adaptation, detailed adaptation, to make the program, such as NCDs, work. And then supervision and performance management. For example, I'd just like to give you an example of something we've developed with TB and evaluated it, and now applying to other. We've done it for malaria, we're now doing it for NCDs, in this case in Pakistan. So we're doing performance management whereby each level of the service is linked. So at the facility level, the different people from the neighbouring facilities in the district come together, the responsible people, and present their results to the facilitator from the district level. And they discuss their performance on certain key indicators being tracked, and the gaps and problems, and look for solutions. And then that facilitator at the district level will present with colleagues, a kind of peer group event again, to the provincial level. And again, look for trends, what's happening, compare between the different districts, and what can be done. HMIS, you know, HMIS systems exist. You don't create something new. You go and look in there and find out, well, what is there? What can we work with? So in Pakistan, for example, we dug deep, and there's a moribund, never used chronic disease card. So rather than develop something new, we, meaning my Pakistan colleagues and I, with the Ministry of Health people, pulled out that card, adapted it to deliver chronic disease, non-communicable diseases, and a simple system for monitoring to follow up those patients, a 3-tray system. Drugs, as I mentioned, you've got to work with the system to get those drugs that you need to deliver that care for chronic disease, in this case, patients. So metformin, for example, and the basic other diabetes drugs and hypertension drugs into the essential drug system. And in Africa, because the primary care is done by the nurse in the health centre, you need to get that the system allows the nurse to prescribe. And finance, as I mentioned, with the insurance system. Another one is about working with the provincial planning system. In Pakistan, it's called a PC1 system. So planning all the things that need to happen for them to be able to expand from our pilot sites, where we're doing our trials, having designed it to be replicable and sustainable, then they can take it to scale across the province by building into their provincial planning and budgeting system. And we work with them from the beginning throughout on all these things so that they are then ready to take it to scale. And they usually do, our partners usually do take it to scale. We've failed in one of our projects if they haven't taken it to provincial scale, say. So our basic premise is that I think, A, we should be working with health systems and services strengthening. And the other blocks are the foundation to their service delivery block, and to deliver coverage and quality of the interventions, and work with the detail of the health systems, understand it, work with it, tweak it, and to enable delivery of those components of the health service, not to bypass it, but work with it and strengthen it. And there's ways of doing that which we've developed. Thank you.